Welcome everybody to today's episode of the Great Birth Rebellion podcast. My name is Dr. Melanie Jackson at Melanie the Midwife. I'm a clinical and research midwife with my PhD. Our Great Birth Rebellion premium members also get access to podcast transcripts, additional resources, the Ask Mel a Question button, and an exclusive monthly Ask Me Anything episode. That said, let's get into it. If you're a midwife who can write scripts for your clients, I've got something for you. Myself and Dr. Kirsten Small are running a free script writing refresher session on the evening of June 19th. It's online, and we're going to run you through the process of writing a script. Some of you learnt that a long time ago and maybe infrequently need to write them. And so we're doing a refresher. It'll count for some CPD, and there'll be opportunity to ask questions. If this sounds like something you need, you can click on the show notes below and register for the free workshop. Welcome everybody to today's episode of the Great Birth Rebellion. With me today is Alison Weatherstone, Chief Midwife for the Australian College of Midwives and a champion for midwives in advocating and fighting for midwifery autonomy and for the midwives to be able to work in their full scope of practice without hindrance. I truly believe that she is the force and hero that midwives need in Australia at the moment, and I have so much faith in her capacity. This is the second time she's been on the podcast, and also she is an invited guest to the Convergence of Rebellious Midwives Conference, which is happening in August 2024 here in Sydney. There have been significant changes to midwifery legislation over the last few months, and it's been an incredibly busy 6 months in the background. And so if you're listening to this in a back catalogue, it's currently June 2024 when we recorded this. And these changes create significant avenues for midwives to change how we're able to work in Australia. And these changes make autonomous midwifery so much more accessible and possible.
Thanks for having me, Melanie. It's an absolute pleasure to be here.
Well, for those who don't know yet, we know that your role is the Chief Midwife for the Australian College of Midwives, but what does that role involve? What do you need to do for that?
So that is a really great question, and it's such a broad role. And I think what I'm still seeing is the role is evolving, but ultimately it is really great midwifery leadership. So often ACM mirrors off the International Confederation of Midwives policy documents, and they have a leadership framework. And we look at leadership in terms of political, operational, educational, clinical. And so there's so many avenues for midwifery leadership, but ultimately at the college currently, this role is really important to advocate. So a lot of advocacy on a national scale, but also on a jurisdictional level in state and territories, and really influence the direction of midwifery because we want to raise the profile of midwifery. So it's a lot of being at the table to have conversations and let everyone know what the role of a midwife is, because often people don't know what our role is as midwives, and also then for consumers what models of care they can access. So we have a number of different priorities that we choose each year, but they really need to be influenced by our members because we need to know what's current in midwifery. My day-to-day looks so different, from events to submissions to policy documents, really connecting one-on-one with midwives, really interested about the career pipeline. So from early career midwifery right through to leadership.
I think what people don't realise is that midwifery is a very clinical role, but it's also it's so politically driven. There's lots of legislations that govern midwifery practice, and there's overarching philosophies that sometimes get in the way of the scope that midwives can work in. So today, I want to talk to you about all the changes that are happening because you guys are often at the forefront of these. So I've got a list of questions. They're in no particular order. For people who don't know yet, private midwives, so midwives who work, self-employed, previously we were required to get a referral or have a collaborative agreement with another healthcare provider, usually a GP or a health service or an obstetrician, who would refer women to our services. And it was only then that we could provide all the services that we're qualified to provide, including prescribing women for pathology, getting access to Medicare rebates. So this was a bit of a hindrance because firstly, not all GPs or service providers would provide this. And secondly, women had to first go and see this particular healthcare provider before being able to access their midwife. Now, Alison, this has previously been a massive hindrance, but they recently announced that they're removing the requirement for a collaborative agreement. Can you tell me what that means for midwifery, how it came about? What's your understanding of this situation?
So the collaborative arrangements was implemented some time ago, and it was an extra unnecessary administrative layer that required midwives to enter a formal arrangement with a GP or equivalent. And basically what we've seen is it is an unnecessary step. So there's been a lot of advocacy over the last 10 years to remove that layer, because what we're seeing is an increased number of endorsed midwives going into practice, and we hope that that will continue to increase, because that really is where midwives can work to their full scope of practice. And so, like you mentioned, the ability to prescribe, whether that's diagnostics, pathology, or certain medications. So over the last 2 years, the Australian College of Midwives has been looking to remove that barrier and looking at other barriers to scope of practice in particular. There is a national scope of practice review underway at the moment, and college has also been really active in providing submissions to that, because we want midwives to be able to work to their scope of practice. And that means provide the autonomous service that they can to women, whether that's in private practice or in the public sector, like we are all skilled to do. So what has happened is in consultation with the Commonwealth Chief Nursing and Midwifery Office, because this is sort of their portfolio, and the current government that has a real interest in women's health, in particular Minister Jed Carney, the Assistant Minister for Health, we have been able to have conversations about removing those barriers. So just only last month, the notion to remove collaborative arrangements was passed in the Senate. So it's actually passed through Parliament now. So the final step is to have legislation changed, and that timeline is to have all of this done by the 1st of November 2024. So what that means is that women don't have to go to their GP to get a referral to go and see their midwife. And often you can't get into a GP. There's just extra over-servicing, really. So women can self-refer to their midwife, and through their own autonomy can provide the comprehensive services that they need to.
Because there was a massive barrier. For example, I had repeat clients who would ring and they'd say, Mel, I'm pregnant again. And I'd say, that's great. I actually can't even see you until you go through this process of seeing your GP, often paying to see them. Sometimes they would decline a referral. They'd have to go to another GP. And then in the process, the GP sent them through all of their usual early antenatal screening, when in fact, midwives are completely capable of referring women for all that early screening. So women can completely skip the step of seeing their GP when they find out they're pregnant and immediately go and see a midwife, which is such a recognition that midwives are the most suitable healthcare providers to be caring for women during their pregnancy, and that pregnancy is not an illness that requires the use of a GP. So I know some people will be sitting there going, yeah, whoopee, this is not a big deal, but it is a massive deal. Was there any pushback from anybody to remove this collaborative agreement?
Well, it definitely wasn't an easy win, because it's been a lot of work in the background. But I was present in Parliament for the first hearing, and there was a group of midwives who were opportunistically there for another event that day, and we sat in the gallery and we were referred to by name by Minister Carney, which really puts a personalised feel on it. And there was a huge round of applause from us in the gallery. So I think that demonstrates how significant this is, and it was such a pivotal day. There is always resistance in politics, and so there were certainly a lot of questions asked, and whether that was through Senate estimates or whether that was sort of in the background. But overall, it was fairly unanimous in that, it got through as a majority.
So this collaborative agreement wasn't only attached to women getting access to their midwives initially. What it's also attached to is our current insurer, MIGA, who provides professional indemnity insurance to midwives. They require us to have a collaborative agreement as part of our policy. Now that the legislation is changing, is that going to filter through to things like our professional indemnity insurance and Medicare and any other parts of our practice that required us to have a collaborative agreement? Is it going to be a blanket removal?
Yes, it is a blanket removal because they've removed the requirement for collaborative arrangements. So I just wanted to backtrack a little bit. There's a couple of things you said in the previous comments, and this also applies to nurse practitioners. But when you said about a woman having to go to their GP and they're having all their antenatal assessments commenced by the GP, and that absolutely sits with the role of the midwife, this will also remove that barrier around the antenatal booking in visit or the antenatal care plan, because often I know a lot of privately practicing midwives had a bit of trouble billing for that because it had already been claimed previously. So in terms of the question around collaborative arrangements being attached to insurance, that will all be removed. That's part of the legislative changes and process. So collaborative arrangements being removed completely, and that means that everything attached to it needs to be unpicked. And I think that is why it has taken a little bit of time, because we know this announcement came in 2023, and then through all of the layers of legislation, politics and administration that's required to remove something complex like this, we've landed on the date of November 24.
Mm-hmm. And that also means when we as midwives go and claim, because there's some government rebates through Medicare for this, when we go in and claim through that platform, we have to put in a provider number for the collaborative care provider. So all those little details, Medicare has to go in and change all these forms and processes to ensure that this unfolds smoothly. The other thing I'm wondering about is previously midwives were also innovating things like getting visiting rights to hospitals. And a big part of having visiting rights to hospitals is having a collaborative care provider who's willing to be the named obstetrician for the women who are being admitted into the hospital with these private midwives. What does that do to those arrangements?
I'm really hoping that this will remove many of the barriers that exist for getting visiting access into hospitals. So there will still need to be some kind of agreement because of the orientation processes and the safety processes that go with providing care in a facility. But the actual requirement to have the agreement as part of a collaborative arrangement, that barrier is being removed. So we again put this into the scope of practice review because we know that access to care is really important, especially in rural and remote parts of Australia, but everywhere. And so we are really hoping that this removal of collaborative arrangements will mean that it will be less complex for a midwife to get visiting access to hospital. And that is certainly a priority of the college, because really it should be, you've got your registration, you've got incredible skill, you're providing continuity care for women. How amazing would it be to actually, for those women that do require to birth in hospital or choose to birth in hospital, that their primary midwife can follow them through? It's a no-brainer for me.
Yeah. Yeah, the current situation is if I have a client who's hired me as their private midwife and they have a particular preference on where they want to give birth, either at home or at hospital, if they choose to give birth at home, but then we transfer into hospital, I get relegated to a support role. I'm not allowed to be her midwife in that hospital if I don't have visiting rights. And when I approached the local hospitals around me about visiting rights, they said that's never going to happen because there's no obstetrician here who will agree to work with private midwives. And so now with that collaborative arrangement being scrapped, that barrier is completely gone. There's no longer an obstetric gatekeeper to midwives getting access to facilities. So if a client of mine wants to birth in hospital, I could now, under this arrangement, take her in, care for her in the hospital as her midwife, not as her support person.
Absolutely. And we already see some midwives are able to do that in Australia. So they've set the precedent. The women want this. So when I hear someone say you never will be able to do that, then that's just a challenge for me. And I think that's an opportunity to break it down. And certainly ACM will look to provide support in that space, both to the midwife seeking the visiting access, but also to the hospital system, because sometimes it's just through either fear or misunderstanding that they don't understand really how easy this is. And to me, it's also a workforce benefit because you are providing the care. They don't have to go and find somebody to provide this care because you're there willing and able and wanting to do it. The woman wants you to do it. Just, it's mind-blowing that people can't see the benefits of it. So we'll just help make that a little bit clearer for everyone, hopefully.
Yeah, and I think it's just misunderstanding and fear about a change in the way things are being done.
Yeah.
And
Yep.
also potentially a lack of understanding of what midwives are capable of.
Absolutely. And I see and hear that often because in my national role, whether I'm talking to politicians or consumers or visiting a site or speaking to midwifery leaders, people don't really fully understand the role of the midwife. And I think we just need to continue to have that messaging to say, look, this is what we do. And you don't want to prescribe scope of practice. That's certainly not what we're wanting to do. But just an awareness about, we provide comprehensive care as midwives from preconception all the way up to, we'll say 6 weeks postnatal at the moment, but there is so much more scope available for those that are interested in sexual reproductive health, child, family, maternal health, and even through to menopause. It's such a unique profession and skill set, and I think we really should be maximising how we work within that, because often we're seeing that the decisions aren't really evidence-based or don't meet what consumer expectation and need is.
And this brings up the next question. When the collaborative arrangements are gone, and say we do start getting access to visiting rights as one of the benefits of that, we currently don't have professional indemnity insurance that covers us all the way through birth. So we've been given an exemption from that because there's no available product. There's been a recent announcement that professional indemnity insurance situation is about to change, which would be incredibly important if midwives were going to get visiting rights to hospitals, because we still have to have professional indemnity insurance. So where are we up to with the professional indemnity insurance issue?
So what we saw is on budget announcement night in May, the federal budget announced that there'll be $3.5 million over 4 years to expand midwife professional indemnity scheme to include indemnity insurance cover for privately practicing midwives providing low-risk home births and intrapartum care outside of a hospital, and for specified entities providing birthing on country models of care. The College of Midwives was quite surprised at this announcement on budget night, because in the lead up, this was a commercial in confidence tender process and conversation. So the college certainly wasn't part of any decision making or consultation around what this insurance solution might look like. And so what we've seen is, with the budget announcement, there was a commitment to have this solution implemented by July 2025. What we know is that there is a little bit of concern around the low risk definition. So what we saw in that announcement is that this cover will come into effect from July 2025, but we know that that means women will be booking in and accessing their midwife from about September, October this year. So even though we think July next year is a long way away, we actually don't have a lot of time to understand what this actually means for practice. So the College of Midwives was a little bit surprised at this announcement, because we hadn't been involved in any conversations around what a PII solution might look like. Up until that point, it was a commercial in confidence conversation, because the Commonwealth were engaging with potential insurance providers via a contract. The college is certainly receiving a number of concerns from privately practicing midwives, and also has some concerns themselves that we need to work through around what the definition of low risk means and whether the exemption will continue or not, because certainly as you read it now, that doesn't look to be the case. So I think from the college's perspective, we are really keen to have ongoing conversations with the Commonwealth, and also to ensure that midwives and consumers are involved in that consultation process. What that looks like is yet to be determined. So what we often see is there's an announcement on budget night, and then they set a target date, and then the actual nitty-gritty isn't really known. So right here and now, I can't actually provide you any information because I don't have it on what this actually means and what it looks like. But what we are doing is collecting midwives' concerns so that we can adequately represent the questions from midwives when we go into those sorts of conversations, which we are expecting and definitely hoping to be a part of.
Mm-hmm. And so we'll put a link in the show notes for midwives who have concerns to be able to click on that and submit their concerns to the ACM, because you can use that in your discussions going forward.
Yeah, absolutely.
So if I clarify then, on budget night, they announced that there will be a professional indemnity insurance package that covers birth, but that would be for women who are considered low risk and giving birth outside of hospital.
Correct. That's how it reads. Yes.
Mm-hmm. And so the concern from the colleges and from midwives is that the professional indemnity insurance product would potentially not cover midwives if they book clients that have perceived risk factors. So anything that attaches a level of what they believe is higher risk of that woman's pregnancy could potentially make the midwives insurance product void. But there will also not be an exemption. And so is the concern that we will only be able to be insured for women who are experiencing a low-risk pregnancy?
So certainly the definition around low risk has not been determined. And if you do a bit of a search online for low risk birth in Australia, you're going to find different things. So that actual definition needs to be determined. What we do have is the Australian College of Midwifery's consultation and referral guidelines, which have very clear pathways for consultation and referral. So even if a woman has a risk factor, if you've consulted and referred, then that should really still be okay, in my personal opinion. But that's the sort of examples that we have to work through, because midwives and women need to be very clear about what this product covers, and they're the conversations we're hoping to have. So it is actually still very unclear because we don't have a nationally recognised definition of what low risk is, but we also know that people's perception of risk is very different. So I speak to this quite often. A consumer, a midwife, a doctor, and a health facility's perception of risk is all very different, even if you provide the same scenario. So it definitely needs further conversation. And we need to be mindful that women are often choosing to birth outside the system for the very reason that the system has influenced that choice. So we've got a long way to go to have those conversations before everyone's comfortable at where we land.
Mm-hmm. And the other question that I had was, currently under the exemption from having insurance for birth, you could invite a second midwife to your birth that's not endorsed or insured to provide services as a second midwife. And in the scenario where the exemption is gone, would that mean that midwives working as a second midwife would need to purchase their own professional indemnity insurance or become endorsed and be acting as a private midwife, even if their main role is not in private midwifery?
So that's definitely one of the questions that we're taking back to the Commonwealth. So the inclusion of a product shouldn't actually make us worse off than where we're at now. So I think it needs to be at least equivalent to the role of the second midwife. If we are unrealistically imposing further restrictions on the second midwife, then there needs to be a bit of a transition so that we can accommodate existing numbers of women that are birthing in the home. And we know that also there's more women wanting to access this model of care and can't necessarily, because there might not be a privately practicing midwife in their area, or there are other barriers. So I think it's really important that we take that question to the Commonwealth and ensure that we're not worse off than where we are now. We have to be at least the same, if not better.
And it's really unfortunate that the ACM were locked out of those discussions, because you guys know the nitty-gritties and the consequences of the decisions that are being made around this. It's entirely possible that the well-intentioned decisions that have been made by government haven't been able to take into account these details because they simply don't understand.
That's a really good point. And I like that you said well-intended, because it definitely was a well-intended announcement, thinking that there was a solution, but it demonstrates the importance of having ongoing conversations with the College of Midwives and midwives in particular, so that you can ensure that whatever product or whatever announcement, that it's fit for purpose. And over the last couple of years, we've had really great relationship building opportunities with government and other key decision makers, and we hope to see that progressing, because as you can see just from the announcements on budget night and the women's health focus, we really are making an impact. So hopefully this is just a little hurdle that we just need to again jump over, just to clarify this is what's actually going on. And often it takes, a clinical practice example. That's why case studies work really well, because if you can demonstrate a woman's journey through the health system and then take that to a member of parliament, then they can visualize it and understand it a little bit more easily. We do have to make it a bit clearer for decision makers, and we've definitely got the opportunity. It's called a little bit of a policy window, where you can jump in and actually clarify things with evidence to say, well, this is why we need to do what we do. And the New South Wales Birth Trauma Inquiry report being handed down this week, there's another opportunity that you can leverage off to actually say, well, this is an example of women wanting to access continuity of care, and as a consequence of something that may have happened in a system environment, if you don't put in practices and change practice basically to make it better, then women are going to seek their care elsewhere. So I think when you join it all up, you can actually take that back and say, well, this is where we need to go with it.
And this would be the role of having an advocacy body like you guys involved in that conversation, because you can join those dots that somebody who's not in this arena, they can't see that, understandably, because there's a lot to be across. And with the professional indemnity insurance, one of the big issues was that there wasn't an insurer who'd be willing to provide a package that would cover midwives for birth. So you're saying that the government's been in conversation with insurance providers that are actually offering a package like this?
I believe there was a tender process to see if there could have been a product that was all inclusive of what we needed to do, but that I think fell a little bit short. So as a result, we're having the conversations we're having now for the low risk home birth. So this is probably the commercial and confidence element that we're not actually aware of, and that's quite frustrating because you know that you want to be able to try and influence and advocate in that space. What I do know is that the number of notifications for midwives is very low, and the number of high cost claims is very low also, but it becomes a risk-based question from a financial perspective, which we know as clinicians we are very human-centred and person-centred, and it's about that, whereas obviously the government has that financial aspect to cover. But we know historically they've been very low numbers, so really the overall risk to government you would expect would be quite low. However, there's just the point of being focused around birth, I think, has that perception that if something goes wrong, that there could be significant costs for a long time into the future and impacts on the health system. So that's all very much also beyond my sort of sphere of influence in terms of the real high level monetary risk assessment. When we think, if we thought of it on a timeline from what we're wanting as a product to everything that you need to go to actually make an end product. So what I believe is that there were a number of tenders that went through into Commonwealth, and for whatever reason they've landed with the announcement that they'll cover the low risk side of it. So all I think we can do is try and get that foot in the door to have conversations so we can understand what happened, and then ensure that we've got an opportunity to have women accessing their model of care regardless of where that is and what that is, and that it meets their needs, and that midwives are safe to practice.
And the government has agreed to financially underwrite that policy. So basically, if there's a claim, the government will be the one paying that out.
Correct. And so that's actually a really positive commitment to midwifery. I think the fact that they've taken that on is a good thing. So now we just have to keep having those conversations to make sure that the women are well represented and that they can continue to access home birth. We probably do need to say that it is going to be a journey, and our expectation as a college is that there'll be information shared and there'll be consultation, and each step of the way we should feel like we're part of that conversation. It's not just an announcement and it's going to happen.
Does the exemption end again? Like, when did this, like the exemption, I don't know what date.
30th of June 2025, I believe.
Right. So I guess that's in place for now still,
Yep.
until solution is
Correct.
is in place.
Yeah.
And so with all these changes, with the collaborative agreement and the professional indemnity insurance, they've also been able to announce some changes to the Medicare benefit scheme and a difference in items that will be covered. So private midwives have access to Medicare rebates. So women who hire a private midwife or an endorsed midwife, they have access to some Medicare rebates. They're not significant when you compare it to other rebates, but it's an amazing step. The government's actually committed to putting more money into Medicare benefit for women who access endorsed midwives. Can you tell us about those changes?
Yes. So the government announced $56.5 million over 4 years to promote the high quality and tailored maternity care by implementing the recommendations from the MBS review task force. And so what we've seen is a commitment to the 5 outstanding recommendations from that review. Again, this is another example of where the detail needs to be worked through. So what we believe at the moment is that there'll be a new complex antenatal care leading to hospital admission and a new 90-minute postnatal item, which can include your birth debriefing and mental health and DV screening, and that's around the 6-week mark. And then there's another increase in the antenatal minimum duration of the antenatal visit. It's highly likely that the implementation group will be re-stood up to actually go through the details of what this looks like in practice. But the best thing is that the outstanding recommendations for the midwife item numbers under MBS have been funded. So now it's just a matter of formalising that.
Have they introduced an item that will cover women for their birth at home? Because at the moment they don't get a rebate for birth at home. They only get it for the antenatal and postnatal.
So I know that was in the report from the Participating Midwives Review report. So we need to clarify whether that is being included. And to me, that ties in with the PII question. So we will be having those conversations. At this point, I haven't got exact information on any of those confirmed item numbers. It was just looking at the report and the announcement. Often this is the way it happens in budgets. So they will announce the funding amount and then they have a period of time to actually roll it out and look at any legislative requirements that are required to actually implement it. And so yeah, that's a pretty decent amount of funding to be committed to. So that looks very promising.
Yes, but I imagine if they do decide that the actual birth will be covered by Medicare in the same way that a hospital birth will be funded by Medicare, they're going to need a lot more money, because one of the major things that holds women back from getting access to private midwifery and endorsed midwifery care is that it's got quite a high out-of-pocket cost. So if the government does honour this and provide a Medicare rebate for home birth, I'm betting that they're going to need to commit way more than $50 million.
I would say so too. But I think the positive step is that we are having conversations about accessibility, more for women actually, access to models of care. And so we're also having the conversation about MBS item for birth, but also women that have private health insurance should be able to access a privately practicing midwife to utilise their health insurance. So these are conversations that are happening in the background. Again, take a lot of consultation and aren't usually very quick moving.
Well, and I think what's really held back the opportunity for this kind of care to be funded by health funds and by Medicare is the sketchy professional indemnity insurance situation. And so now that that could be solved, and that we don't need collaborative arrangements anymore, then this opens up the door to fund things like that. Because that is the other issue, is that a lot of women who can afford to hire a private midwife do also have private health insurance, but their private health insurance will cover a private obstetrician but won't cover a private midwife. And so these changes open the door for those changes. So I love the direction that the ball is rolling in. And I see now we just got to keep pushing it on track and not let it roll down the hill in the wrong direction. Now, the other big barrier, so we've already removed the barrier of collaborative agreements. We're now removing the barrier of professional indemnity insurance. The other big barrier for midwives is that in order to get endorsed, you have to do so many hours and an extra qualification, and it's a real hindrance to midwives who want to work autonomously. They need to spend lots and lots of hours. It's 5,000 hours working in a model that will sign off that they've done those hours. And this is a real challenge because women in midwifery, we have babies. We're doing midwifery at the time in our childbearing years, and we take time off. And those 5,000 hours are supposed to be finished in 6 years. And it's happening to midwives where the hours are falling away, where they have years and years and years of experience, but still can't qualify to be an endorsed midwife. And their next option is that they just leave because it's almost impossible. So I know nothing was announced about hours, but what I'm hearing along the grapevine, that it's being really looked at to reduce the hours that the midwives need for endorsement. Can you give us any information on that?
Yeah, I'd love to. The Australian College of Midwives has been really proactive in trying to remove the requirement for 5,000 hours to become endorsed, for the simple reason that there's no evidence to actually support that number of hours. And if you look internationally, there really isn't a comparison to that 5,000 hours. In the National Scope of Practice Review, we've written about that, and it is a barrier to increasing the number of endorsed midwives. We will also be representing that through consultation with the Midwifery Futures work that is due to be finalised this year, and hopefully that piece of work will inform the Health Department and especially the Nursing and Midwifery Board of Australia around the removal of the 5,000 hours. So I know it's very much on everyone's radar at the moment. So hopefully it's only a matter of time before we see that hours removed. I don't have a number at the moment whether that will reduce to a magic 1,000 or whether it will be removed. I don't have that information, but I know that we need to make it accessible for midwives to join the profession and also become endorsed. And the other thing that we will look at is the feasibility of putting prescribing into the undergraduate space. But if we can start by removing the barrier of that 5,000 hours now, we're going to see a lot more people interested in obtaining their endorsement.
Well, essentially what will happen is it will be set up and inbuilt that when midwives finish their training, they come out as endorsed midwives. I mean, it makes so much sense. We are autonomous practitioners like that.
Yep.
But that's what it sounds like we're working towards, is if you want to work as an endorsed midwife, you come out of your training with that. There's no barrier of the hours. And it sounds like by what you're saying is the hours could be completely removed altogether, or maybe be given the value of 1,000 hours, but certainly not 5,000, because that takes 3 years full time to complete. So that it's a massive barrier.
Well, the other thing we're hearing from midwives is that because it's in the previous 6 years, if you've gone on maternity leave or you've had a variation in your career, you may well have had that 5,000 hours clinical experience in your collective career, but because it hasn't been in the immediate 6-year period, then it deems you ineligible. So it just doesn't make sense, especially even if you've just consistently remained part-time in the workforce. So I think the people that need to make decisions around that are very aware that it is a huge barrier, and it's probably an easy fix in terms of removing that barrier. That's, I guess, what we're agitating for at the moment.
Do you have an inkling of when they might take the hours away? Because there's midwives itching to get out. They're just literally counting their hours.
Well, I would be hopeful for an announcement this year, but I can't put my finger on that because I'm not a decision maker. But I think when we look at the two reports in particular that this is focusing in, it's the Scope of Practice Review and the Midwifery Futures Report. Both of them are due between now and September. So hopefully it would be a fairly quick win in terms of recommendations from those reports if they're there. And they've certainly been featured up until now.
And another big win in the budget was that the government is going to fund student placements, will pay students to be on placement, because a really big issue is that students, midwifery students who are studying, then they go on these big blocks of placement, which are unpaid. And so they sometimes need to take time off their paid work that they would normally be doing through the semester. And we call it placement poverty. And the government's recognised that and committed money to paying students to do their placement. Can you tell us the details of that?
Sure. So this is a really exciting announcement. I think it's an entry level announcement. So I think we can always do a little bit better. But at the start, it will take the heat off some students doing their clinical placements. But we conducted a member survey and found that the average age of students responding to that survey was 29 years. So often midwifery students are not school leavers, and they will often have either pre-existing financial commitments like home loans, or they've got children, or a number of different factors which make the clinical placements really quite challenging. And we know with the continuity of care experiences that go along with the midwifery degree that you need to be on call and ready to go and follow your continuity woman through. And so that makes it really hard to undertake paid employment, even outside of clinical placement blocks. So on top of that, we know that students that are seeking to have a placement in a rural facility, or the reverse, they live in rural and they're wanting to come into metro for a clinical placement, then the cost of accommodation, parking, meals is almost untenable for a lot of people. We recently heard that one student had to pay almost $2,000 for accommodation in the Sydney metro area to undertake a placement. And people don't have that in their savings, especially when they're on reduced income as well. So the clinical placement funding will enable, it says eligible students, and I think it's sounding like it is being means tested. So what a lot of academics and institutions like our universities and a lot of students are raising their voice around having that not means tested, because everyone's impacted differently, and also potentially looking at increasing the amount of the funding. But to have raised the concern with government and then have that announcement so quickly, it's actually a positive step forward. And I think if you look at things like the Council of Deans Future of Midwifery workforce paper that they put out, and a lot of the papers on student poverty, it is a very real thing. And if we want to encourage people into the profession and sustain the workforce long term, we have to make it more accessible to undertake training.
This is a rogue question. You don't have to answer it if you don't want to. But there's a workforce issue with midwives leaving the profession, and most hospitals are short on midwifery staff. Is there any action towards remedying that circumstance?
I would definitely like to hope so. So if you look at a lot of ACM's positions, it's around increasing midwifery leadership, it is placement funding, it is help debt removal, and all sorts of things that will actually go to improving workplace culture. I can relate to a co-campaign we did with QNMU recently in Queensland, which had 4 priority outcomes. And what we saw was the government actually actioned those 4 outcomes. So they appointed a chief midwife, increased continuity of midwifery care access, implemented midwifery to patient ratios in the postnatal ward, and increased access to publicly funded home birth. So we know that those 4 together will go a long way in improving access for women to models of care. But also it's really important that you have, as midwives, access to your professional development, and you also work in a place where you're valued and you have excellent interprofessional communication and positive workplace culture. So we're doing a lot of work to really promote that Just in the last week, I spoke to a graduate midwife who's already left the profession after 5 months. And when I really heard her story, I don't even have words, but I was just really saddened to hear of her experience. So we all have an opportunity to get in there and make our workplaces better. And I think if anyone's got ideas, I'd love to hear them because I think, again, there's an opportunity. I feel like there's some funding around for midwifery and we're raising the visibility of our profession. We just all need to sort of link arms now and come together to support each other to improve that culture and just not take bad practice or unsafe practice as okay just because it's a workforce issue or there's no one else to do it. I did a recent parliamentary inquiry also, and I know workforce was a key conversation point because people are leaving and we need to stop that.
I really want to encourage people, if you want to actually be able to lend your voice to this and, send Alison an email and give that college feedback, you've got to be a member of the college. And the college has enough CPD hours to virtually cover your entire year of CPD for a really small fee of being a member. And what you also get is to tell the ACM what you need as a midwife. And then the ACM takes all that information that they've gotten from their members and then takes it to government and says, here's what the midwives need. But you don't get that if you're not a member because, the ACM is there to hear from members and to serve the members. And so I just want to encourage midwives, if you're really despondent with the way things are going and you don't know what to do, a really easy way to offset that feeling of hopelessness is get a membership with the ACM, and then you've got a platform to add your voice. And so we can all do something. The ACM has got a seat at the table at most tables, just not the PII one at the moment, but it's coming. And so I just think we can all do something, even if the only thing that you do is become a member of the college, because that increases the capacity of the college. So, okay, wrap up. What we've got is a very new announcement about the introduction of professional indemnity insurance for endorsed and private midwives that may cover home birth. It's still in the works, but it's a step forward because we currently have had an exemption from that for about the last 12 or 13 years or something. The removal of the collaborative agreement, that's a sure thing, and that is going to roll off into our current professional indemnity insurance and Medicare requirements. They're looking at funding new Medicare items that, with the changes to PII, could cover the opportunity for women to have a funded home birth with a private midwife. But it's also opened the scope for additional antenatal services and postnatal services like birth debriefing. There's the funding of student placements, which will make becoming a midwife a lot easier. There's also the very real potential of the removal or reduction of the 5,000-hour clinical experience requirement in order to be endorsed. And then down the track, actually embedding the pharmacology and diagnostic qualification into the undergraduate midwifery degree so that when midwives leave uni and start working as midwives, they have the full scope of opportunity to work in any clinical setting that they want, with access to Medicare, with access to professional indemnity insurance, without the barrier of having to go through a GP or have a collaborative agreement. They could work at home or at hospital. That seems like the big goal.
Absolutely, it is.
We are actually getting so close, Alison.
We are. It is a really exciting time to be a midwife.
I could really feel it. Like I'm looking at the barriers coming down, and these things are always slow because there's so many people involved and there's so much paperwork and so many actual consequences to the changes. So it seems like it's slow, but I feel like this is actually quite a fast pace.
Yep. I think we just need to leverage off that momentum and just keep going. And like you said, by being a member of the college, the more we can say we've got this many midwives and this is their position and this is what they want, it is super effective.
So midwives who are listening, if they have extra questions about this or if they have any feedback, where can they go to give that?
Yep. So they can definitely contact the college. If you go to the Australian College of Midwives website, you will find all of the contact details on there, and please reach out because we also want to know what you want and need as being a member of the college, whether that's an education topic in the CPD that's missing, or whether that's some business resources or whatever it is you need. We're really keen to hear from you and make it it's all about the members, really.
And we'll put all the details in the show notes below.
Excellent.
And Alison's also going to come and give us another update, among other things, at the Convergence of Rebellious Midwives in August. You could also bail her up and ask questions there. There'll be an ACM stall, and so heaps of opportunity to engage with the college and enact and be an active member in the changes that are going on at the moment in midwifery. Thanks for the update, Alison. It's always nice
you're very welcome.
Get, the real information, not down the grapevine, from the actual person who knows what's going on.
Absolutely, and I'm more than happy to share the information.
We're so grateful to have you, and I do feel that midwifery leadership and all the politics behind our work as midwives is in amazing hands with the ACM, and I just want to thank you for your tireless work, and we want to support you. I'm curious to know, what do you need that makes your job easier?
I need to know what members want and need. So it's really that positive communication loop. So if you have a question, from my perspective, I really need to understand what's happening out there in reality. And I pride myself on still being clinically recent and contemporary, because I have to keep abreast of what's happening in reality to be able to influence high level. So for me, I need the passion of people to want to stay in midwifery and to want to make midwifery better. So so much strength in numbers, and I just need to. I know it's a challenge. I know it's hard out there, but if we know what those challenges are, then we can continue to advocate, because there's been so many strong advocates for midwifery over the last forever, and so we still need to maintain that momentum moving forward to make sure women everywhere in Australia can access a midwife for birth.
And when you're working in this way that you are, you're not always in front of people, in front of midwives personally. Getting digital feedback from emails and feedback from forms and social media, and when the ACM puts a call out for feedback, that's the kind of stuff that can keep you going. And the sort of stuff that really saps your energy is senseless criticism that doesn't offer any solutions or support. I just want to also encourage people that if you don't have some constructive assistance to give, actually in midwifery, the best thing to do is either tell somebody else, not Alison, and save your constructive feedback and suggestions to feedback to the college so that they have something to pick up and work with, and that doesn't actually take the energy out of the work that you're doing. So that's my encouragement to people listening. And I just want to thank you again, Alison, for being so open and honest with this information. And for our listeners, I'm always happy to try and get more information out of Alison at another time. So if you've got any questions that we can collectively bring to her, I do feel like those are going to be welcome in this circumstance.
Thanks so much, Mel.
Oh, thank you. All right. We'll see you guys in the next episode of The Great Birth Rebellion. If you have some feedback, information, or questions for Alison, she has a direct line that she gives people access to email her. She tells me that this email account is an email account that anyone can use, and it goes directly to Alison. It's not filtered. It's a direct line. This is a unique opportunity. If you've got something you need to share with the college, the email is in the show notes below and is also sent out to the people on the mailing list. Thank you for being here for today's episode of the Great Birth Rebellion podcast. If you want to get access to all the resources that we use to create every single podcast episode, you can join the mailing list at melaниethemidwife.com, or better still, the Premium Members Hub. The Premium members get access to transcripts, the Ask Mel a Question button, an exclusive Ask Me Anything episode every month. All the details are in the show notes, and I will see you in the next episode of The Great Birth Rebellion.